Good afternoon, everybody. Thank you so much for coming to our event today at the Bander Center. So the Bander Center is an ethics center housed in the School of Medicine at St. Louis University. We have an educational mission as well as a scholarly arm. The Bander Center was founded in 2007 based on a grant by the BF Charitable Foundation. We're an open center, meaning that anyone is welcome to collaborate with us. I invite you. Come to our meeting, contact me if you'd like to collaborate with us on a scholarly project. I'm Jason Kuhn, the Executive Director of this center. Before I have introduced my guests, I'd like to give some shout outs. We are happy to have our local PBS affiliate KETC Channel 9 video recording this session for YouTube. It's not going to be on TV, but their video, we're very pleased that they're able to do the video recording. They're masters at that. We thank Brian Compton for doing the sound in this room. And in the house today is my favorite St. Louis independent bookstore. That is Left Bank Books. I'm so glad you could be with us today. Welcome, Elisabeth Rosenthal. Thank you.
Thanks. It's thrilling to be here.
Thank you. So I would like to start off this with talking about social media. I know that social media has been a great way for you. It's a tool to get the voices of patients who are not getting what they need. The system is not working for these people, and they're on social media. So they really have no other voice than this grassroots one, and they don't have a seat at the table. So social media like this, which really didn't even exist 15 years ago, is so transformative of so many aspects of our culture. Can you talk a little bit about how social media plays into your work?
Sure. Well, it drastically changed journalism at the most simplest level. In the old days when I first started reporting on healthcare in the 1990s, if I wanted to find out about patients, I would kind of camp out in a hospital parking lot and accost patients or people who were leaving the hospital in the hopes that they had a story. And I used to say it was low yield and cold, not very fun. And then what happened is I kind of left healthcare reporting for about 10 years. And when I came back, social media had started to grow. And I was curious about it as an experiment. So basically what happened is I wanted to do a story about healthcare costs for the New York Times and how Americans were being affected, because I really felt like, the on-off switch. It's crucial. I wanted to understand how it was affecting real people. And I was thinking, okay, I'm going to do a series about healthcare costs, but oh my God, I need patients. How can you do a narrative without good patient stories? And I contemplated this long series in all the hospital parking lots. And I decided to try a little experiment, which felt very experimental at the time, which was 2012. So it doesn't, but dark ages of newspaper social media. So we put up a little item on the Well blog. It was about a study that appeared in JAMA Internal Medicine, where a college senior, actually from Washington University senior, named Jamie Rosenthal, who had no relation to me, did a summer project where she called 100 hospitals in the US as a kind of fake shopper, pretending to be looking for a hip replacement for a grandmother who was 63, had good insurance, but needed to know what it cost. And anyway, so she called 100 hospitals, and as you might not be surprised, many of the hospitals couldn't give her a price after repeated calls, after spending a whole summer. When they did, they said, oh, somewhere between $40,000 and $100,000. And anyway, I wrote a little blog post for the New York Times Well blog about that. And I just put a little note at the bottom. I said to someone, well, could we put just a little note at the bottom and say, tell us your story. Do you have an experience with high or unknowable medical prices? Tell us your story. That went up on the Well blog. It was never in the paper. It was up for about 3 hours. And within 3 hours, we had 500 fabulous responses. Fabulous responses, like I could have spent a lifetime in parking lots and not had those people. Those people, I wrote a series called Paying Till It Hurts. It was a 12-part series. The first 6 of those people, the first 6 of those stories were based on people who responded to that initial blog post, including the young woman in New Hampshire who had a pregnancy that she had to shop for, including a guy who had traveled to Belgium to get a hip replacement. that was $100,000 in Seattle, and he got it for $13,000 in Belgium, including airfare. So, I mean, there were wonderful, wonderful stories, and more than that, there were people who called me. Normally, as a journalist, and you're talking about healthcare, people are had often been a little reluctant. These people were like, no, I've been waiting to tell this story, and I just didn't know what to do with it. And there were often people who'd taken those first steps. They'd kind of, Mike Chopin, the guy who went to Belgium, he'd gone so far. He had insurance, but this was pre-Obamacare, so it didn't cover a hip replacement, which was considered a pre-existing injury for him. He'd done everything right. He even decided on the joint implant he wanted. He'd gone to Stryker and found someone he knew who knew a sales rep and arranged to buy one wholesale. He put together this package and realized he would use his entire retirement account. And the wholesale price of that joint was $13,000. In Belgium, he had the whole thing done soup to nuts, including rehab for $13,000. And he was a great story. He now teaches snowboarding in Colorado on his new hip to disabled children. I mean, you couldn't have found this perfect example. And over time, we had, so each story led to the next, and each time we did a story, then we put a little call-out box saying, tell us your story. We had so many stories, such a litany of all the ways in which our system isn't doing right by patients, that by the end, by the second year, my editor could say to me, you know, I don't think we've done enough about African-American families, and we need a case from California, and I could search our database of, you know, gee, I need a good family, a good African-American family in the Bay Area who has problems with asthma, and I would find a story there.
Wow, yeah, fantastic. I wonder, you know, oftentimes when we talk about healthcare costs and so on, they say, you know, average patient is not at the table, right? They don't have a say, they don't have a voice in that conversation. I mean, do you envision this grassroots kind of way of listening to patients as a movement? I mean, that could actually take on some substance, you know?
Yeah, I think in medicine it has tremendous potential. I covered climate change for a while. That's really a hard thing to use social media for, because people will say things like, well, it was really, you know, I don't believe global warming because it was really cold here last weekend. But, you know, everyone knows what happens with their medical bills. Everyone has, as a reporter, I asked to see everyone's bills, their explanation of benefit statements. Everyone knows what, even people without great educations, they get those bills, they know what they mean, they have to write the checks. So I think this is an area that's ripe for social media, and I think it's an area where people don't have a lot of good outlets. You know, we say to people, oh yeah, you know, you're not happy with that bill, write to your state insurance commissioner. Okay, sure. You know, you can search the website, you might find an address, they'll say, yeah, fax us your complaint, and you know, 18 months later you might get a form letter. So this is where I think this could really, social media can be the start of a patient movement, a patient political movement, and encouraging people to be healthcare activists and healthcare consumers and healthcare voters. I think it has huge potential. And just to plug something which some of you may find interesting, as a result of that series, at the very end, we started a Facebook group, not a Facebook page. I don't do Facebook as a person, but there's a Facebook group called Paying Till It Hurts, and it now has 9,000 people. The New York Times, I should say, discouraged me from starting it. They said, oh, you know, it's going to take a lot of work. Who's going to join? I'm the only administrator. It's now 9,000 people, physicians, patients, lawyers, activists, social workers, a broad range of people, and there are wonderful discussions on healthcare costs there. And I'm mostly in the background. You know, people put their bills on the site. People put their shopping for health insurance on that site. They show pictures, screenshots of what they're encountering, and others weigh in saying, yeah, you know, this is what's happening in Tennessee, or this is what's happening in Missouri. It's an incredible tool for mutual support, education, and I think ultimately could be a tool for giving patients a seat at the table so they can have a voice. I hope it coalesces into something much bigger than what it is now on social media.
Right. Well, thank you for your book. I mean, I've been thinking about healthcare costs and bioethics and social medicine for a long time. And one thing that's really hard to discover from the ivory tower in which I am, is the cost of a hip implant. I mean, I was so discouraged when I was a junior scholar from doing stuff about cost. They said,
Right.
don't go there.
Right.
You know what I mean? It's impossible. But what you have done is to at least uncover it's like pretty kind of anecdotal, one at a time kind of things. But there's some mind-blowing numbers in that book.
Well, there's some mind-blowing numbers in the book, but it's also mind-blowing to someone who's a journalist that you, as a surgeon, can't know what a hip implant costs at your hospital. And I hear this over and over again from doctors who work in an emergency room who ask their hospital, well, what does the MRI cost? And they're like, well, we're not going to tell. The amount of research work they have to do to figure out what's being billed for the things they're doing is mind-blowing. And I love that. I love the work I do. I love that there are all these transparency sites now, like Healthcare Blue Book or Clear Health Costs. But I think at another level, it's really tragic. When I go buy broccoli at West Side Market, I don't have to crowdsource how much it's going to cost.
It says it right there.
I mean, that's a ridiculous process to expect physicians and patients to go through.
Yeah. Well, if it's okay with you, we'll switch gears a little bit. Let's talk about a different topic for a little while. I wonder, one concept that I heard, that I read in the book that I'd never heard of prior to reading your book was this notion of having generic devices, and generic devices and implants. So you write, Dr. Blair Road, an orthopedist who is trying to kickstart an industry for generic devices, estimates it costs around $350 to manufacture a hip or knee implant in the United States. And you compare that then to current prices, like at NYU, where you can get a metallic knee implant for $36,000. And now, so generic medications have been around for a long time and have come under some, scrutiny and some fire of late, right? So, but this generic device thing is new, as far as I know. Maybe not. Maybe you can correct me on that. But first, question is kind of like, why haven't generic devices proliferated like generic drugs have? Is it just a patent thing or what? And then second, is it a great opportunity for some creative policy making in this arena because it's a developing field,
Yeah, well, I think it says a lot about our healthcare industry that they haven't evolved. We say we trust in the market, and the market would say, oh my gosh, if there are these devices that are metal and ceramic and you can sell them for $30,000, why wouldn't everyone rush in to sell them for $20,000 as a generic? And the answer, which I discovered, which I think was pretty alarming, is people in the device industry call the 4 device makers left in the US and essentially in the world the cartel. And they are at some level, and that's a kind of toxic word to use, but basically all hip and knee implants are made by 4 companies now. It was 5 last year. And when I started doing research on this, I discovered when I was calling the companies for comment to try and understand why there aren't generic makers after I spoke to Dr. Road, I discovered that all of them had the same, or 3 of the 4 had the same area code, and I thought, that's weird. So it turns out that most devices in the US and the majority in the world are made in a little town called Warsaw, Indiana. Device makers there, and this is the problem, the FTC looks for collusion. You don't need active collusion to keep prices high when, a mixed marriage is one person works for Biomet and the other one works for Stryker, right? Everyone's happy that they all get to charge $30,000 for an implant, and there's very little pressure to have a price war. Now, why aren't there generics in that setting? Well, look what these companies do, and I'm not sure if anyone in the room is a resident. They are very much like Apple and PC, and I'm an Apple and a PC. I'm a Mac person, right? So my whole world revolves around Mac. I have an iPhone, I have a Mac, it's all in the cloud. If you're a young surgeon going into orthopedics, these companies make cultivate a particular hospital. You know, Mass General will be a Stryker hospital. Beth Israel Deaconess will be a, and I'm making up the connections, might be a Smith and Nephew hospital. The department chairman will often have some kind of arrangement with the company. Maybe they'll do consulting, research, invent things for them. All the residents learn on that device, and the devices are a little different. They also have to be installed often on operating tables that go with the device and using instruments that go with that device. And one thing I didn't know, which is probably really alarming, or should be, is that there's often a representative, a sales rep from the device manufacturer in the operating room when these things get put in. So you are wedded to this world, and so when someone comes along and says, you know, I'm the target of devices, and I can sell you this implant for, you know, $500, you're like, well, what operating table would I use? I don't know how to use it. I'd lose the guy who hands me the instrument that I need right at that moment. There are huge barriers to entry in the field. And there's also, you know, licensing and, you know, getting FDA approval. But actually for devices, that's pretty easy.
Yeah, wow. Yeah, it's different, right?
It's
than
much
medications.
easier.
So you go into that somewhat in your book.
Yeah, and I mean, one of the telling stories is, you know, the device makers, because they have a pretty closed market, will introduce new devices each year. New, meaning somewhat different, like the female knee, the metal on metal hip, which turned out to be a bad new thing, right? Because a lot of people had to have those taken out. But the people who are in that world, first of all, that's the information they get. And second of all, they're often stuck using the new thing, because often the game is you take the old one off the market. And there's a wonderful story in the book by about a urologist named Dan Elliott, who's at Mayo, who I mean, this is really obscure stuff, but it's very telling. He does valve implants on men who've had prostate cancer surgery. And he does more of them than anyone in the US. And so the device maker that he always worked with for those little valves came out with a new, you know, infection fighting valve that was double the price. And they said it was much better, it's infused with antibiotics, and you know, he used it for a while and charged the higher price, but then didn't notice there was much of a difference in the infection rate. So he thought, what's the study show? And of course there was no study. He did a study which showed that there was no difference. And then started presenting this at urology conferences, and the device maker went to Mayo and said, can't you shut him up? You know, this is a problem. And finally, what happened was he talked about this a lot, urged all the urologists to use the old device. And guess what? The response of the device manufacturer was to raise the price of the old device to the price of the new device. So, you know, he said he did what he could, and he couldn't do much. And that's why, you know, I look at poor surgeons who try and do the right thing, and it's very hard.
Yeah, this is my world described precisely, right? I mean, so, you know, I've used one company's stuff, and it was that way when I started. The reason I'm told is that, you know, they sent bids at one point in time, made a decision to make a contract with this company, and so we get lower prices on this company's products. Good. You know, kind of talking about devices, though, you know, I was excited when I read that there's such a thing as generic devices, but then it's kind of tamped down. You know, Martin Shkreli, EpiPen, the thing you say about, you know, collusion or, you know, oligopolies, just increasing the price of generics. Maybe we live in the 21st century now where it's, you know, who cares if it's generic or whatever. I mean,
well, I think in the device world, there is the space for generics because it's not an approval issue. It's a market, breaking into a market issue. You know, Dr. Rode has found that because some of the devices, he's a spine surgeon, some of the devices used in spine surgery are like screws you could, and a device manufacturer, a salesman said, essentially these are things you could buy at Home Depot, but they're sterilized and sold for a lot more. So he has found a way to sell some screws, some of the smaller non-system kind of devices in a generic way. But it's ripe for disruption. Now, there's a lot of resistance to that, both at the hospital level, from your department chairman probably, and all the way down the line, and now increasingly from patients who see some of this stuff advertised and go, oh, I want that female knee. You know, Art magazine is filled with advertisements for like what kind of knee implant you should want.
That's wild. Yeah. I'm thinking about another little part of the book that's sort of like this. It's about putting mesh for, I guess, vaginal prolapse, and talking about, you know, why this happened. This is a disaster, right? I mean, all these meshes had to be taken out, and, you know, there's kind of the notion that there are these kind of device reps who are preying on the junior doctors or the uninitiated or the kind of the green ones, you know, that kind of a thing. But don't you think it's more than that? I mean, I guess I'm a junior. I'm in my 4th year of practice. Okay. So, you know, but, you know, I get that rep all the time. And, you know, he's always giving me data, and I say data schmata, and you know what I mean? But he's trying to get me to do all that stuff. And what do you think? I mean, is it just the juniorness, or is there something bigger?
No, I think it's something bigger. You know, I think there's a lot of research there's been a blurring of marketing and research that's really toxic. You know, you set up studies to show what you want to show, and you don't ask about what you don't want to show. And we tend to reward things that have a business model, and things that don't have a business model you won't hear about. And that's really a big, big problem when we're in this market-driven world where we are trusting, you know, you hear from pharma, oh, you know, we need to charge these prices because that's what generates drug development and innovation. Innovation depends on profit. And that is true in a certain sense, but it also means that things that don't have a business model don't get innovated. Yeah. And that's a huge problem, and that's the problem with generics, I think.
Right, yeah, I mean.
For devices, at least.
Now, I'm really curious to kind of merge those two things. Okay, so we're talking about how there's a blurring of research and marketing, which is well known. It's been written about a lot. And then there's this idea of, you know, the patient grassroots movement, you know, social media and so on. Does that stuff ever come up from a patient's perspective?
The marketing or the?
Well, the blurring of research and marketing, because it's so obvious to me, but I don't know what it is from a patient perspective. I mean, does that ever? It may not. I mean.
Well, I think, you know, you can fault the media here. I mean, you know, what have we seen the last week now? Half of all America has high blood pressure, right? And if you go to certain doctors, you will get a pill for that high blood pressure, because in our system, which is very income focused, it's really a lot easier to write a script for a high blood pressure pill than to address the underlying causes of high blood pressure in our population. And I heard, you know, a very optimistic, but I think not very realistic interview with Harlan Krumholtz of Yale, who said, you know, no, this shouldn't add to a lot of people on medicines. It should encourage people to do what we know reduces blood pressure, you know, exercise more, lose weight, eat a healthier diet. And I think our system doesn't reward that in any way. Especially, you know, and one of the bees in my bonnet is we tell people now, go shop for new insurance every year, right? Shop for a better deal. Well, great, if I'm an insurer, what am I thinking then? I have no long-term interest in this person's health. You know, I don't care what they're, you know, I'm not, give them a pill for a year and then they'll be on to someone else next year. Right. So I think if we want to trust in the market, which, you know, many of us are skeptical by itself in its current form will produce in any kind of solution, you know, it won't produce good medicine. It will produce profits.
Right. Yeah, let's go there. I think that's good.
Sorry. Sorry.
So the market. You know, we have kind of. Let me put the big picture there. Right. We have this idea of highly calibrated capitalism coming out in the book as maybe a solution. I know your book is really kind of agnostic about these issues on purpose, and I respect it so much for that. But what is highly calibrated capitalism, and how could that work? And then we'll talk about the other end of the spectrum.
You know, I think what's called highly calibrated capitalism is used in Singapore. And basically the idea is everyone has a health savings account, There's a basic level of health care which everyone is entitled to, but if you want a private room or you want an exclusive floor, you pay for it. If you want to live in a hotel while you're in the hospital, unlike in the US where virtually everyone now lives in hotels while they're in the hospital, you have to pay a lot for it. So I think they do a lot of transparency, showing what different things are cost so consumers can decide how they want to use those dollars. But also, and I think this is critical and why it might not be plausible in this country, is they start with reasonable prices. You know, if you wanted to do a consumer-based healthcare system where you said, okay, we're going to charge a 10% copay and that will help people make better decisions. If we were starting in a world where x-rays cost $200 or MRIs cost $200, then you could say, sure, people could use that to make better decisions if it was transparent. When we have now entered a world where an MRI might cost $1,000 or $10,000, and you have no way of knowing that in advance, this notion that patients can make good decisions is absurd. And some of the people in the book, they have, for not very complicated things, $100,000 hospital stays. You can't ask people to do a 20% copayment for that. So to go to that highly calibrated capitalism, which involves tons of transparency, a bit of price setting, so you can't just charge whatever you want, and a lot of enforced savings from a very early age. This is not an optional thing. So many different things would have to change in our country that, I just wanted to point out in the book that there are more regulatory solutions, there are more government-based solutions. I mean, there's price setting, there's single payer. There is this option of a real market that maybe could work. I wanted to point out what the array of options are, what we will go with in this country. I'm a journalist. It's not for me to decide. That's a public decision. And it shouldn't be just a decision in Washington. It should be what people think works best for them. And I can tell you, objectively, because I don't have opinions, I'm hearing from more and more physicians who feel like, okay, and I wouldn't have said this 5-10 years ago, but I'm ready for Medicare for all, a public option, some kind of single payer system. Basically because they're so fed up with the dysfunction and the price of this system. And likewise patients, my patients who I hear from are mostly pretty happy with their care. They are very unhappy with the agonizing process and the worries, the financial worries that it causes them. So, I kind of am with, when President Obama left, he said, hey, if those guys can figure out something that's more affordable and gets people good care using the market, hallelujah, fine.
Yeah.
But, I haven't seen that. And I haven't seen that in other countries yet. I think if you look around the world, what you see is countries either have to do what Singapore did, starting with lower prices, or you go to Germany, Switzerland, which are market-based systems but have a lot, that have a lot of rate regulation. This is what we should pay for this, or a single payer system. When those countries do rate regulation, they enforce some of the basic rules that our market seems incapable of enforcing, such as in Japan. You have a new scan, right? When MRIs first came into the world, they were great. But so you could charge a lot for them. But every 2 years after that, they have to come down in price because they're not such a whiz-bang technology anymore. So what you see in Japan is that MRIs now, echocardiograms, will cost $100 to $150 if you're paying, right? What you see in this country is that price has gone up and up and up and up because the market allows it to.
Wow. Okay.
So.
Yeah.
Sorry.
What a predicament.
Yes,
we're in.
what a predicament we're in. But
So-
there are lots of solutions.
Yes, so maybe I can ask you a question that doesn't require you to reveal an opinion.
Okay.
And maybe it is sort of an opinion, but so it's going to require, this is my word here, revolution, in order to get to something like a highly calibrated capitalist system, right? I
Yep.
mean, so it's going to require something like a revolution to get to a single payer system. Which one is the insurmountable? Which one is more insurmountable, I guess? Let's say that. Which one are we
Well-
closer to? You know, is
Well,
there,
I
is that
think
an
there,
answerable question?
yeah, I mean,
I would like to say, though, I am not in any particular camp, but I would say when people say single payer, that's revolutionary, that's too crazy, we could never do that. I just want to point out some facts, and I'm not saying that is the solution we will go to, but before Canada had a single payer system, it didn't. And when the Canadian Broadcast Network asked who was the most important Canadian of all time, it was Tommy Douglas, the guy who started, I think it was one of the province's first provincial health system, you know? So some politician maybe could do well. The other thing, though, is it's not really, it doesn't have to be a cataclysmic event. I mean, we are talking now about, people have been talking about allowing for a public option, right? Maybe people with chronic diseases, like people with kidney failure, should be allowed to come into Medicare at earlier ages so they don't face these costs. Hillary Clinton, before the last election, and many people now are suggesting, let's start lowering the Medicare age. Let people in their 50s either get in or buy in. You know, you could see in this country that resulting in, okay, that worked well for that population, let's lower it again. And sooner or later, you would have a Medicare system, single payer system, and you'd wake up one morning and go, how did we get here? You know, how did that happen? Yeah. So I think that we obsess in this country about labels rather than thinking about, well, what does this mean and what does it mean in practical terms? And all of these things you can shift towards in a cataclysmic way, which I would not suggest in this country because so much of our economy depends on healthcare and healthcare jobs, so we have to move somewhat carefully and somewhat slowly, but you can approach any of these changes incrementally too. And I would say once you start with incremental moves, you see if and how people like them, and then they can really pick up steam. And I think we've waited for this like grand all or nothing solution, and that's prevented us from doing the things we should and can do now.
Thank you for that. Let's see, we've had a lot of success with getting questions from the audience in these events. Would that be okay?
love it, yeah.
Okay, great. Is there anybody who would like to address a question to Dr. Rosenthal? When we have a microphone, go ahead. Actually, right here in the middle, in the front, in the gray shirt. Thank you.
It's on. Okay. Hi, my name's Hassan. My question was about, I'm sure you're familiar with how generic drugs have their, like the base price set kind of by CMS, and so the manufacturers take turns kind of making the drugs to get them to where they are. What do you think about a way in which we do that with the generic devices? So for example, Biomet, Zimmer, DePuy,
Yeah.
you know, all these device manufacturers are forced by CMS to basically come out with like a schedule or whatever, and they have that generic floor of price. Would something like that work in your experience?
You mean having a generic price that, in some kind of national price for
Right, yeah. So, like for example, it wouldn't force people to have to change, like from, like if Mayo's using Biomet, for example, and MassGen's using Stryker, they don't have to switch, but at least it would control the rising costs, because every single time they come out with these incremental changes to like the engineering of the device, they do raise the price.
Right.
Or if you have to like take a Biomet versus a Stryker, if you force them to make it similar, they may force them also to redesign it to make it similar in terms of engineering.
Yeah.
So then your operating tools will be similar, your tables will be similar, the reps will be more overlapping. But to get back to the point,
Yeah.
would the price floor work in a generic setting? This is two ideas combined in one.
Yeah, well, I mean, what you're talking about is some form of national price setting, right, for devices, basically. And yes, one of the most amusing things about Michael Chopin's experience in Belgium is he sent me his bill, which I like to say was far easier to read than a hip replacement bill in the U.S., and even though it was in Flemish. It basically it was one page, it said, double comma, double room, implant in, and the device he got, which would have been $13,000 in this country wholesale, was $3,500 there. And it's because that country has a national price setting for devices, and they don't let anyone come into the market who does not accept that price. And it's very successful. And, Zimmer, Stryker, Biomed all sell very happily there. But we have been very averse to any kind of, interfering with the market, even though we all know the market is broken, and even though we interfere for markets in a lot of essential goods. So I think, that discussion is a really important one to have. It's ridiculously simple. One of the other things the book that Jason alluded to is to get new devices approved. You go through a process called 501(k), which doesn't require a whole lot of vetting. You just have to say that your new device is similar to an old one and used for the same purpose, which has allowed all these meshes onto the market, even though the original mesh device was pulled from the market as being dangerous. The subsequent Me Too devices said, oh, that one was bad, but ours is okay still until proven bad. So I think, yeah, we need to, step one, of course, is, even Medicare can't negotiate drug prices for its beneficiaries. Do they have to, Switzerland doesn't impose, nor does actually Great Britain in its National Health Service, doesn't impose on pharmacists a set price. They say, here's our corridor. You bargain to see what you can get in that corridor, but you can't just charge anything. So I do think it's an interesting idea for these device makers.
Thank you for your question. How about over here? Before you start, just wait for the microphone. And I'm going to try to repeat the question a little bit.
Hi, my name's Scott. Thank you for coming.
Sure.
I haven't read your book yet. I will after I take a step, because I don't have time right now. I have read T.R. Reid's book, The Healing of America, and I really enjoyed that. One of the big issues that he discussed in the book, though, was something that I feel like a lot of health professionals don't want to talk about, but we're going to have to deal with if we do pursue a single-payer system, is the issue of doctor pay.
Yeah.
How are we going to approach that? And where should we try to be? Because really talked about, how in other countries they don't get paid nearly as much as doctors in the US do, but they don't have to deal with hundreds of thousands of dollars of debt and having to pay all that off. And so it's kind of like our system is just really set up with this, having the debt and then having to try to pursue these specialties with a lot of money so that you can pay off your debt and not being able to go into primary care because you have too much debt. How do we approach that?
Yeah, and that's partly why I wrote the book. I think if you look at any one part of our system, you don't understand why it is. You can say, oh, these doctor salaries are too high, which, objectively compared to the rest of the world, they are often much higher. But then how did they come to be there? They came to be there because our medical school tuitions are high. Most other countries doesn't have. They came to be there because our hospital CEOs and all the administrators are paid, $1 million+ and the doctors rightly, I think, and justifiably feel like almost Marxist. We're providing the labor here. And I heard a lot of that when I was working as a doctor, where there was a lot of grumbling about like, oh, this administrator makes $1 million or the device salesman. This is what you hear from every orthopedist, my device rep, he makes, he has a nicer house than I do, so I deserve more. So it's part of this this natural, though abnormal, inflationary cycle that has happened, spooled out over the last 20 years. And I think we do need to reel that back in somewhat. I think we need to right-size primary care salaries a little bit. Probably we'll see a reduction of specialist salaries. The idea originally is that specialist salaries should be related to the length of training. That I can support. That's a rational thing. I want my neurosurgeon to be paid well. But when you look at the highest paid specialists now, they're often the people who figured out how to game the business of medicine. So nothing against dermatologists. I have some great dermatologists as sources, but most surgeons are highly paid and are not doing the most difficult and needed work in this country. So I would like a little more, and the market will take care of some of that, but not if patients are deciding, because you go to a dermatologist, the dermatologist says you need Mohs surgery, and you're going to do it because you trust that doctor. So I think, I have my little solution for med school is I feel like, fine if we're committed to this loan thing, let people take out loans, but if you go do something in an underserved area, or you go into a specialty that we need more of, then, you don't have those loans. We're going to repay them. All these hospitals that say they do, community benefit and charity care, the loan should be taken over by someone else if you're doing something we as a country decide we need. If you want to be a dermatologist in suburban New Jersey, pay your loans off. That's my attitude. And then at least we would take away this real burden that I know medical students feel to, we know objectively that doctors pay back their loans just fine. But I have a 25-year-old daughter. I know when you're coming out of medical school with $200,000 in debt, that doesn't feel payable right then, and it will influence your career decision.
Could you spend about maybe 1 or 2 minutes just talking about your relationship with yourself here, where you're wearing multiple hats, right?
Right.
Here you're on a tour talking about your book. You're also the, pardon me if I get this wrong, the editor-in-chief of Kaiser Health News,
Yep.
which is not part of Kaiser Permanente, as you're fond of saying.
Yes, not
Not
affiliated,
even close.
never
Yeah,
was.
exactly right. And so those are two hats. They do sort of, overlap somewhat, but I suspect not all the way.
Not all the way, and
how
I
does that
think,
go for you?
well, we're part of Kaiser Family Foundation, which is a data foundation, data and polling. So they have always been kind of religiously nonpartisan. They provide numbers. They will tell you what Medicaid rates are in different states, what the effect of, the reduction of subsidies in the ACA, how that will change people's premiums, who it will help, who it won't help. So they are very avowedly nonpartisan, and they 6 or 7 years ago decided to start this nonprofit news service. And my goal in that role is to connect these really kind of obscure policy decisions in Washington to people's lives. So next election, they understand what they're voting for and how this narrative, whether they like it or not, repeal and replace, you can decide whether you want that, but decide understanding what's the interest of yourself and your community. Now, I like to feel the book is nonpartisan in the same way. I don't think, we had some discussions because I had written the book while I was agreeing to go to Kaiser Health News. I'm sure they were a little nervous, like, what's she going to say in that book? Right. But I think they're more or less aligned. There are occasionally times when the foundation people who are, researchers will say to me, wow, that tweet was a little further out there than I think that I'm comfortable with. And I feel the world of social media has changed journalism to allow it to be a little more infused with opinion. But I don't think it's opinion to say our healthcare system is broken, it's too expensive, it's not serving patients well. To me, that's like saying, I'm against poverty. Is that advocacy? Well, if it is, I'm there. But I think it's just objective that we need to do something now. And if I were writing a different kind of book and didn't want to stay a journalist, my book would probably have a lot more opinion in it. But I do think where we go at this crucial moment in time, I think we're at a tipping point. I think people are fed up, physicians are fed up, We can't afford to keep, we say, oh, medical spending, the increase is leveling off. It's not actually decreasing. It's just not increasing as much as it was. It's still often, most years, increasing more than inflation. And someone said to me, it's like saying, wow, we're on a diet and we're patting ourselves on the back because we're just gaining weight slower than we used to. We're not, and I think that's really where we are. We've got to do something. And I wanted to just lay out for people, for individuals, for doctors, for people in the device world, in the pharma world, that we are at a tipping point, that we need to do something, and that we all can do something. Each and every one of us, I think, can do something in the sphere in which we exist. It may feel pretty futile at the beginning, but at least knowing you're part of that community that is doing something to make the system better, I hope and I think will be impactful and rewarding.
Right statement that I hope will inspire several members of this audience or our
I hope
YouTube
so.
viewers. Could there be one more audience question before we adjourn?
So earlier you mentioned enforcing a health savings plan for people to move away from the current insurance-based model that we have.
Yeah.
How would you propose to enforce something like that when people are already, living paycheck to paycheck?
Exactly,
and,
exactly. That's why I say, this idea of calibrated capitalism that has worked very well in Singapore. It may be that the cost problem is so out of the barn in this country that, if you're in a country where there is this, they say the philosophy is this is a personal responsibility. People from birth should start saving, and you can, great, I did that for my kids' college. It was hard, we did it, but to ask people to do it for healthcare and college, I don't know where people are going to come up with the money. And you really don't want to go to the private university model which is kind of what we do, which is like, oh, the tuition is $60,000 a year, but send us all your taxes and we'll decide, what you're going to pay. I mean, with health encounters, they're too numerous. There's a very long, painful process in applying for financial aid, and I would not want that to be our model for healthcare.
Thank you so much, Elisabeth Rosenthal. Really appreciate
Thank
your
you.
visit
This
to
was
St.
really
Louis
fun.
and your interview with me.